Inside a hospital ward, a hidden countdown begins the moment a laboratory analyzer flags an extreme deviation in a patient's blood chemistry. These minutes are critical. The patient's physiological compensation is actively failing, and survival often depends on the speed of the clinical response. These results are classified as critical laboratory results. They represent values so far outside the normal range that they pose an immediate threat to life. For example, a potassium level below 2.5 millimoles per liter can trigger fatal cardiac dysrhythmias. A hemoglobin count falling under 7 indicates a severe risk of hemorrhagic shock. This data originates in the laboratory, often in a different wing of the hospital. This physical separation creates a gap between identification and care. While the lab is strictly controlled, the bedside reality relies on the care team's ability to interpret data while managing active patients. The transit time of this data from the laboratory to the clinician represents a significant window of vulnerability for the patient. When this communication chain fails, the consequences include cardiac arrest, unmanaged hemorrhage, and the rapid progression of sepsis. Data shows that human transmission error under pressure is the primary risk factor during the reporting process. To mitigate these risks, the Joint Commission International, or JCI, established specific accreditation standards for critical value reporting. JCI audits these requirements as core metrics of patient safety. Every healthcare organization must operationalize a structured, closed-loop communication method to ensure information remains accurate from sender to receiver. These standards function as an evidence-based clinical fail-safe, engineered to protect data integrity during medical emergencies. JCI-compliant care follows a 4-step sequence known as the Standard Communication Flow. Step 1 is laboratory identification. Policy forbids any delay between the moment the result is confirmed and the start of the notification process. In Step 2, the nurse receives and acknowledges the result. This role is the central link in the chain and the primary point of accountability. Step 3 is physician notification. Nurses use standardized tools like the SBAR format to relay the clinical situation clearly. Most hospital policies require this notification to occur within 15 to 30 minutes of the nurse first receiving the result. The final step is full documentation. Every detail of the event must be recorded in the patient chart immediately following the interaction. Deviating from this sequence, including skipping a verbal readback or delaying the physician call, creates a gap in compliance and patient safety. The most vulnerable moment in this process is the verbal transmission of numbers and units over a phone line. Delayed notification is a frequent failure point. A lag of even a few minutes can allow physiological instability to become irreversible. Omitting the readback leaves misheard data uncorrected. This is a direct violation of JCI standards. Failure to confirm the patient's identity using dual identifiers, like their name and medical record number, risks delivering an urgent intervention to the wrong person. Finally, incomplete documentation, such as missing exact timestamps or the names of the communicators, creates a significant legal and clinical void. Breakdowns in these specific areas are the primary drivers of catastrophic sentinel events in critical value reporting. Consider a patient admitted for dehydration who has a critical potassium level of 2.3 millimoles per liter. This value indicates severe hypokalemia, placing the patient at immediate risk for cardiac arrest. The nurse must immediately stop all non-urgent tasks in order to give the incoming critical laboratory call their complete and full attention. During the call, the nurse performs the mandatory readback, repeating the exact value, unit, and patient identifiers for verbal confirmation from the lab. The nurse then notifies the physician using SBAR and records the exact time of the call in a 24-hour format. Immediate interventions follow. In this scenario, the priority is placing the patient on a continuous ECG monitor to watch for dysrhythmias. The nurse also prepares for the expected order of intravenous potassium replacement, verifying the safe infusion rate. The application of the readback protocol ensured that this vulnerable patient received the correct life-saving intervention without delay. JCI-accredited institutions track every critical value event as part of their quality and safety programming. For readback compliance, hospitals maintain a target of 100%. The goal for adverse events resulting from communication delays is 0. Audits also look for 95% completeness in documentation, ensuring that names, times, and actions are accurately captured. These metrics are diagnostic tools used to identify systemic gaps and drive continuous improvements in care delivery. Clinical nurses serve as frontline patient safety leaders in this process. Accurate, timely tracking of these values can determine whether a patient recovers or experiences avoidable harm. The takeaways are non-negotiable. Critical results require immediate action. Closed-loop readbacks are mandatory, and exact documentation is essential. This structured communication builds trust and clarity across the healthcare team. Every single readback and every documented call is an act of professional excellence that protects a human life.